See here in one set. Yep, there we
Yeah,
go.
cool.
You're set. Thank you.
Uh,
Okay. We are recording. So now let me go ahead and share my screen with everybody. And voila, come on in. Okay, all right. Not the greatest visual presentation, but it's all we have to work with. Okay, I was hoping to have IMAX all set up for you guys, but it just totally fell apart. All right. I'm going to be talking about trauma, and in particular, not just trauma, but something called trauma informed. That is, if we know or suspect somebody has experienced trauma, what do we do about it? How do we approach things? What's the best way to deal with somebody who might have experienced trauma, might be currently experienced trauma, and what could we do to make sure that we're not contributing to more problems? Okay. Hello. All right. So, boy, that's hard to read. I'll just read it for you. We're going to identify 5 different kinds of trauma based on the DSM-5, which is the book that psychologists use. And then we're going to talk about 7 particular ABA procedures that may not be a good idea for somebody who's experienced trauma. And I'll go into reasons why. I will spend a little time talking about something called learned helplessness, which is a phenomenon that happens to individuals, humans and other animals, when they are exposed to uncontrollable situations that may be traumatic for them. And the whole idea here is that by the end of this discussion, I will show you that you can't just talk about trauma from a psychological point of view, mainly because it's an incomplete picture. And we tend to talk about things as incomplete pictures when it comes to trauma. Psychologists have not done a very good job of this. Fortunately, brain science has. So I'm going to introduce some brain science research to you guys, which is showing that what we are experiencing when we experience trauma might be psychological, but no doubt it's actually physiological reactions. And these are things that are unconscious and they are basically genetic responses to things that happen to us in our environments. No need to talk about psychology to explain this stuff. Bioscience has already got it nailed down. But this is new research, and I want to share this with you, okay? So, allow me to get into this as quickly as possible. If I could ask you guys, save your questions until the very end so I can get through all the material. I went online to look up what trauma means, according to the American Psychological Association, and they say trauma is an emotional response to a terrible event like an accident, rape, or a natural disaster. Those are the things which qualify, according to the APA, as true traumatic types of events. What is not a traumatic event? Shutting off a kid's video game 15 minutes before bedtime and causing a meltdown is not a trauma. I think we could all agree upon this. But unfortunately, there are some parents who will say, no, that's traumatic for my kid and I won't do it. And here's the take I have on that. Rather than dealing with a behavior problem, it's a lot easier to explain away the problem by saying it's something called trauma so that as a parent, you don't have to do anything. It justifies the fact that you're not going to lift a finger to try to change your kid's behavior around this stuff. And here's the bigger takeaway on that. I think parents undergo trauma. I think when they deal with kids problem behavior day after day after day in uncontrollable situations that leads to them having to drop everything to go to school to help out with it because the kid's having a meltdown in school or in the community. This adds trauma to the family. And this is something I'm going to talk about, is that trauma is not just at the level of the individual. We need to look at the entire family to see that the fact that the trauma is spread throughout the family. It's not just the kid that you're working with, okay? The first kind of disorder we're going to talk about is reactive attachment disorder. Boy, I wish I could get this. If I could get this out of the way so you could read it. There we go. Inadequate attachment to early life primary attachment figures. This leads to an inability to seek or respond to comfort from a caregiver, or individuals may be emotionally and socially withdrawn and lack any positive affect, or they may be irritable, sad, fearful during non-threatening interactions with their caregivers. Okay, children with this issue do not seek comforting, nor do they respond normally to techniques used for children to calm them down. They completely respond differently to it. They don't respond very well to social cues of warmth and caring that a parent may give. And oftentimes it's not surprising that we find kids like this coming from impoverished environments, or they have gone through multiple caregivers as children, foster care, okay, institutionalized kinds of settings. These symptoms that we're talking about here are not due to ASD. This isn't a social issue relative to ASD. This is basically something that which is the kid has it has been inflicted upon the child, these kinds of environments. Okay. And let me go down here to well, actually, what happens is that the time period, we're going to go through that if I could advance my slide. Oh, here's why. Voila. Okay, there's my advancer. Okay. Okay, here's the development course. We're basically looking at a situation where this occurs prior to 9 months of birth, from birth. It's within the first 9 months that you start seeing reactive attachment disorders. Okay. One of the things that we'll learn about, or I could at least tell you about, if the kid has actually undergone adaptation and transfers and foster care kinds of transfers, and that's within the first 0 to 4 months, and it's really early in their development, you're probably not going to see reactive attachment disorder that early unless it's very abusive. Chances are the child is developing a little bit further than 4 months. It's really the 9-month marker. But here's the problem. It's sometimes difficult to actually find the developmental stage at 9 months to be able to assess that in general. So this becomes tricky to try to nail down reactive attachment disorder types of diagnoses. Okay, only because the criteria that we're using makes sense, but it's tricky to nail down exactly where they are in their developmental stages, and do they have any kind of verbal communication, or probably not at that age, not really a whole heck of a lot. So there's, you start seeing these responses to caregivers, and it starts raising questions. When did we start first seeing this? Not necessarily when did the abuse start happening. When did we start identifying this on our clock? Okay. The other thing to note here is that borderline mild ID between the ages of 5 and 9, we see the symptoms of reactive attachment disorder in about 16 to 18% of our kids. Okay. Contrast that with something which is very different called a disinhibited social engagement disorder, which is just the opposite kind of display that you would get. Here's what happens here. You get inappropriate and developmental inappropriate sociability with adult strangers. It's often exhibited through inappropriate closeness to individuals, such as sitting on their laps walking away with them, holding their hand and walking away with them without even glancing back at your parents or caregivers. It's impulsivity. And this becomes hard to diagnose because when kids have this, you also see these same kinds of behaviors sometimes in kids with ADHD. They're impulsive. They make bad decisions. So the question is, which is it? But the powers that be at the APA and in developing DSM-5 believe that this is something that can be concerning because kids who have this problem are targets for sexual predators. And they're also targets to be abused sexually and physically. So that's why it's categorized like this in the DSM-5. It's something to keep an eye on, okay? All right. Another kind of traumatic event is called a PTSD, post-traumatic stress disorder. What we're looking at here is chronic disorder. It develops in response to traumatic exposure, often cyclic, okay? And it's progressive, gets worse over time. Symptoms comprise biological, psychological, and social functioning. Persons with intellectual disability, because they have an intellectual disability, they're likely to be more vulnerable to the development of PTSD because of their environments being somewhat chaotic at times. Not always, but a lot of times it is. Okay. More often exposed to conditions known to contribute to PTSD. That's typical with people with developmental disabilities. And persons with mild intellectual disabilities, their presentation is going to be pretty similar to what you would see with somebody who's neurotypical. But as the intellectual disability is more severe, you're going to see a whole lot of other behaviors in response to the PTSD. You won't necessarily see that in neurotypical or higher or mild ID. There's something called an acute stress disorder. This is symptoms very similar to PTSD, but it's acute. And what that essentially means is that the symptoms last from 3 days to 1 month. So after 3 days after the incident, you start getting these symptoms, but they eventually resolve within about 1 month, possibly even up to 2 or 3 months. They resolve by themselves without any further therapies that have to be done. Okay. All right. Symptoms include intrusive thoughts, negative mood, dissociation, avoidance, and hyperarousal. Okay. Now, an adjustment disorder, the symptoms, again, have to be identifiable to psychological stressors. The stressor may be a single event, or it may be multiple events that are going on. It develops within 3 months of the stressor onset and typically resolves within 3 to 6 months termination of the aversive event or the traumatic event. Now, one of the things I'm going to point out here is that when these things happen, what does it look like? And one of the things I want to point out here, when you approach and you're stressed out, one of the first things that we oftentimes see is immediate passivity. You don't see scrambling, escape, and avoidance behavior. You see just the opposite. You see freezing behavior. It's like you stop dead in your tracks and you don't move. Even when the stimulus is presented over and over again, you don't do anything. Okay. Now we would oftentimes say, well, that's part of the trauma. You're traumatized, so you can't respond. But it's a lot more to it than that. That's sort of circular reasoning, right? If you're frozen, you say that it's due to a trauma. How do you know? Well, look, they're frozen. That's circular reasoning. Something else is going on while this is happening. And the other thing here that happens is that we oftentimes see a delay in the escape responding. That is over a period of time when you're exposed to aversive events, eventually you start doing something about it. If you start doing something about it a little bit quicker, it's probably going to be an acute stress disorder. But when you have PTSD, it just goes on and on and on. It does not resolve by itself. Okay. The other thing we're going to talk about in a couple of minutes here is that when you're looking at these behaviors as traumatic behaviors, responses to traumatic events, you got to look at it within the cultural view of the family. What may seem innocuous to us may be traumatic as heck to another individual or to a family that they've gone through it. And the same thing can hold true is that what's traumatic for us, and we say, God, I couldn't deal with that. It may be nothing to the family, which is why it does not necessarily get addressed in the household, because they just look at that and say, what's the problem? Okay. Okay. On top of an adjustment disorder, if that's not bad enough, you could have on top of that an adjustment disorder with depression, adjustment disorder with anxiety. You can have it mixed with anxiety and depression. You can have a disturbance of conduct from this. You can have mixed disturbances of emotion and conduct. But what you don't have here is you don't have an adjustment disorder with psychosis. Psychosis is its own animal. Okay. All right. I want to talk now about what trauma-informed means. So what I just went through, these are the categories of trauma based on when did it happen? Did it happen early in your childhood or did it happen later on in life? How long was the event and how much did it interfere with your social and education and psychological functioning? And these are just ways that we've learned to describe these things so we could all talk to each other and say, yeah, it's not PTSD, it's an adjustment disorder. We just use these labels to try to categorize as much as possible. I want to point out, these labels don't explain a damn thing. They're not meant to explain anything. They're meant to describe what you're seeing, which means that we still have to explain why this is happening. Before we get to that, I want to talk about Dr. Kohlru's concern about having us become more of a trauma-informed culture. We, according to her, should learn about the unique history of individuals and their families. Because when we're treating one individual, guarantee that individual's response to treatment is going to be affected by the family. I'm going to come through some examples over here in a second. But we want to ask a question. We are evidence-based in ABA. We're trying to be evidence-based in everything that we do. But what does that mean? It just means that we look in the literature and we have data to support the interventions that we are doing. In other words, if we have a person who has this problem, we look at the literature and says, here's what you want to do with the person with this problem. There are standard operating procedures that you do. Okay. But that's based on evidence that this treatment will work. Part of that is it all depends on whether you could get the treatment through the front door to the family. You can have a standard operating procedure of certain medications that you take. But if the family doesn't follow those rules, what good is evidence-based? It becomes useless information. So some of the things we want to ask the question is, our ABA is ABA therapy and behavior therapy treatment met with resistance by the family. Now, you could say the same thing with OT and speech and with mental health. Is the family on board with it? Are they putting up barriers to you being able to work with the kid or the patient? Okay. And you already know we have this problem. Okay. The second thing is that do rules and regulations providing treatment clash with cultural beliefs? And here's some of the rules and regulations we have that we work with. One of the things we do is we come up with dosages of what kids need in order for them to have successful outcomes. We do an assessment, we say, we are recommending your child have 30 hours of ABA, and they have 2 hours of OT and 1 hour of speech a week. That's what we're going to recommend. Now, we know where those numbers come from. We're confident when we come up with those numbers, but what does it mean to a family to do dosage like that? You know, a lot of times they don't follow it. They a lot of times will say, what do you need my kid for 30 hours for? You know, I can't do that. I don't have the capacity to do that. I've got a whole life of other things that I've got to do, and my kid's in school. And I am being told by the school, get your kid into school because that's more important than anything else that's available to them. And we know that to be probably false. Okay, so they get stuck and say, I could only do 5 hours out of 30 hours. That's not good, right? That's well underdosed, and we're not going to make progress under those conditions. And a doctor would say the same thing if he said, I'm recommended that you go on 1,500 milligrams of Depakote to control your seizures, and you say, sorry, I can only do 500 a day. And your doctor's going to slap you around a little bit and say, what are you doing? What are you thinking? You will have seizures if you don't do this, right? Another thing, we do work in home. That's a whole another cultural question. You are going into people's homes to conduct ABA therapy. We're going to be shortly doing that with OT and speech as we get our own in-home services approval nailed down. That's going into people's homes. And you're going to address the way they run things in their home. You can't go in there and tell them what to do. Okay. And the third thing is that training. Families still don't get it that the heart of what we do requires that they need to be trained themselves. They need to come in and they need to learn these techniques because we're not going to be here all the time. Our goal is to put ourselves out of a job. Do what needs to be done, give them the treatment, teach it to the family, and let the family do it from that point on, and then your job is done. This is the expectation from insurance companies and from Medicaid. The interesting thing is that Medicaid expects us to do that. They just want to pay us a nickel to do it. Right? All right. I want you to be aware that these are red flags in a kid's development and their history. If you see this, particularly if you're doing ABA, you should be concerned and you should hold off in doing what we call standard operating procedures. And here's some of the activities that kids might have been exposed to. Food insecurity, food-related abuse, neglect, and food deprivation. And we know who we're talking about with that, don't we? Travis, right? Yeah. Sexual abuse and physical abuse. Medical complications related to sexual abuse or physical abuse. Behavioral problems related to undiagnosed medical issues such as celiac disease. You don't come in there and start doing feeding programs if you don't know what a kid's susceptibility is to foods and so forth. What happens if they're allergic to peanuts? Whoops, and you give them peanut butter, or they're exposed to peanut butter. Bad news, okay? Adverse circumstances that they might have experienced, death of parents, removal from an unsafe home, immigration, poverty. And add in there, by the way, never underestimate how devastating the loss of a pet would be to a kid or to a household. Inconsistent caregiver in childhood consistent with reactive attachment disorder. Be aware of that. And we do have kids that are, we have kids who are in that category. And then finally, involvement with law enforcement and school suspensions. You just hold off on doing standard ABA procedures, which are as follows. Using edible reinforcers to reinforce appropriate behavior. Probably not a good idea to use that with somebody who has been having their food controlled and deprived for a period of time. Doing one-to-one oversight with somebody who's just gone through sexual abuse. We would recommend that you don't do that. You're doing a session with the kid, make sure the door is open. And make sure that there are other staff around who can actually serve to make sure that everything is going okay. Okay. Toilet training procedures. Got to be careful about that. And we do a lot of that. We're emphatic about doing toilet training here. I truly believe that the greatest gift you can give a family is to have a kid toilet trained. And if you could do that and start the process, that opens up so many doors to kids and families. Okay? Attention extinction. In other words, when the kid is trying to do things to get your attention, ignore them. Probably not a good idea, and you could end up with something which is a disaster when you do an extinction procedure. I'm very careful when I do extinction procedures, even with people who have not gone through this. Extinction is a very tricky procedure to do to pull off really well. Right? DRA or DRO procedures. We want to be cautious on doing that as well, differentially reinforcing alternative behaviors, because some of the things we may be asking them to do and appropriately selling them to do, they might have actually gotten punished for doing those things that we're trying to teach. Okay? Timeout from attention reinforcement. Right? In other words, we put a person in a timeout area and then we minimize any kind of attention we give them during timeout. That could be a disaster. We monitor people in timeout. And even then, we don't really use it that often. We only have a handful of situations that will require that. Attention praise statements for compliance. Kids get sensitive to the fact that you're giving me praise, but any second you're going to place demands on me or possibly abuse me. So you got to be careful when you say good job doing such and such. Sometimes those have been used as coax lines to get a kid comfortable so that they can bring them into a closed area and abuse them. You got to be very careful with that. And then finally, least to most punishment. We don't want to use punishment in general in ABA. It's just something that we shy away from. But parents do this all the time. Do this one more time. Here's what's going to happen. That's your second shot. Here's what's going to happen to you. Here's the third time. Okay. And it's not laying out that you're going to get reinforcement for doing it. It's laying out that you are going to get into a lot more punishment than you are in right now. Okay. Threatening is coercion. So what Kalu recommends is that we start supervising RBTs, BTs, and BCBAs and train them to be able to understand what trauma is all about. The second thing is to make sure you read the documents and history on a person. Ask questions. Talk to the family as much as possible. If they're coming from a hospital setting and you know that they have been in a hospital for an evaluation, get that evaluation and discharge someone so you can read it and know exactly what's going on. And finally, when we do functional behavioral assessments on what's going on with this kid in this environment, I'm going to try to do the same thing and try to figure out what's been going on in their history. What's the function throughout their development? Has this been an ongoing escape and avoidance behavior that's been going on for a long, long time? Okay. So, standard operating procedure, when a kid comes in who's either neurotypical, ID, or whatever, but we know that they have not had trauma. This is what we typically do. This is our standard. This is what we tell and we train BCBAs and RBTs to do. We want to pair ourselves with good activities to build rapport. Sometimes we pair ourselves with food. We deliver food. We say, come with us, and we become the sources of snacks for them or edible reinforcers, or just general fun. Standard operating procedure. When they look at us, we reinforce eye contact, right? Particularly if they have ASD, we may want to do that. We conduct standard preference assessments to figure out what they like to do, what's important to them, what's not important to them. And we reinforce often, and we require them to do something to get that reinforcement. That's the standard operating procedure we train everybody to do. But when they've gone through trauma and we suspect trauma, we're going to go in a little bit slower and we're going to look at the context and circumstances behind their behaviors. Not just what's going on now, but what's going on in their environments at home. We're going to look at the risks and benefits of using certain ABA procedures. Some are actually contraindicated that we don't want to use. We want to determine what prerequisite skills that they need to do to be successful and train those skills. And then we want to determine the best course of communication. so that we can kind of get everybody on board as an entire team. Now, we've done this with some of our kids who are undergoing trauma that we know for a fact that they've had reactive attachment disorder kinds of histories. Okay. Any questions before I start now getting into learned helplessness? Yeah. They should be on Central Beach. Well, what we potentially what we get from the doctors. Talk to the BCBA. The BCBA should actually go, yeah, let's get this history. Let's talk to mom. We got to make sure we have releases of information signed, which should be on the very first. When they come into this organization, we get releases of information so we could talk to people. That should be the first order of business. Okay. And then we just put down the name and then you contact. Now, once you contact the children's hospital, doesn't mean you're going to get the report like that. You might not even get the report at all. I was just in a conversation with somebody about this, that we don't get, sometimes we don't get squat. And it's really frustrating. If we get it, it's 4 months late. I think I was thinking, I don't want to use names of certain OT and speech organizations that are out there. But we were talking about this yesterday relative to getting important information in a timely manner. Because what happens is that we need to do our assessments and we want to be timely and get the kid assessed and get them into services as fast as possible. And Cindy is doing a great job doing that, but she's sitting here going, I need the report. I need the report. When am I going to get the report so I can complete this? And the family complains, and they're complaining about OBC, that they're not turning around the report fast enough. And the problem here, it's not our fault. We're not getting the information we need to do this. So, okay. All right. Learned helplessness. How am I doing on time? Oh, we are good. Cool. Okay. Back in the late 60s and early 70s, a guy by the name of Martin Seligman, did a series of research studies with a guy named Steve Mayer. And their studies were to look at the situations which give rise to severe depression and immobility following aversive events. And one of the things Seligman used to talk about, and he defines, what does helplessness mean? Helplessness is essentially happens when outcomes, when we engage in behaviors and responses, the outcomes to our behavior happen independent of our behavior. Has nothing to do with anything we did or didn't do. The event would have happened regardless. And what he talks about here is that gives rise to helplessness. Not necessarily that you're getting reinforcers by something you may or may not have done, but in particular, you are being exposed to aversive stuff, noxious aversive stimuli, and anything that you do is not going to make a difference. You could try and try and try, it's still going to happen. And if you don't do anything at all, it's going to happen. This is what he talks about in terms of helplessness. It's the belief that nothing one does, anything one does matters. And it leads to essentially immobility. So how did these guys study this? Well, the question they want to come up with is that, is this phenomenon psychological? Or is it something that's a real physical thing that's happening to our physiology, to our bodies? So they devise a study, which is called the triadic design. I'll get right to it here. And this is the way they did the research. They studied a variety of animals, humans and other animals, dogs, rats, and a variety of different animals, exposing them to these conditions. And here's how the design works. Originally, it was done with dogs, and it was done with noxious noise that dogs do not like. Now, that could be a range of different things. For my dogs, I don't know if you guys got dogs, but one thing my dog cannot stand is when the smoke detector battery is going down and it beeps every 30 seconds. Both of my dogs have visceral reactions to it. They're whimpering, they're crying, they're literally shaking. more than I've ever seen them shake before due to a stimulus that's going off. Now, they've been exposed to what happens when the alarm goes off. And it only took one trial learning for them to note that this is a noxious stimulus. So this is the kind of stimuli that were essentially being used in Seligman's research. He had 3 groups of dogs. Group number 1 was exposed to noxious stimuli through the loudspeakers. They were in an experimental room, a room that was about 8 feet by 8 feet. And they were allowed to roam around. And there was a lever in the room on the wall. And as soon as the noxious noise came on, all the dog had to do was go over to the lever, boom, and the noise went off. When the noise comes on again, walk over to the lever, press it, it would go off. This is classic avoidance, escape and avoidance responding. It's actually escape responding, right? It's the same sort of thing that happens when, you know, I get a message on here while I'm on the phone and another call comes in. And a way to avoid that, just hit the send the message to them, I'm busy, right? It's an avoidance response, okay? So the dogs all learned to do this successfully. And then the conditions changed where the dog had to learn a brand new response. And the new response is that there was a square panel on the wall. They had the lever in there, but the lever didn't work anymore. Now there was a new panel in there. It's just a flat square that was about 6 inches by 6 inches square. And now the dog had to press against that square with its nose. And that was the avoidance response. Okay? Everybody understand that? So avoidance response number 1, they learn it, they get it down, they have experience avoiding bad stuff. And now we're going to teach a brand new behavior. What do? Okay, that's group number 1. Group number 2 was called the yoked group. And here's what happened to group 2. They were in the chamber or the room right next to the other dog. Whenever dog number 1 had the noise come on in their in their experimental space, dog number 2 got the same noise at the same time. Okay. But dog number 2 did not have a lever or a square to escape and avoid. They had nothing. They had to sit there with absolutely no means to change that situation. However, if dog number 1 went over and pressed the panel, right, to shut off the noise, it immediately shut off the noise for dog number 2. So dog number 2's life was dependent on dog number 1 for getting rid of aversive events. So everybody follow that. Now, what that means is that if you find a difference between group 1 and group 2, you cannot attribute it to the fact that dog number 2 got a lot more noise than dog number 1. They were controlled. So that's not the variable of importance. Something else is. And it's not the loud noise that's the important variables here. It's the fact that they don't have a means to control that event. That's the issue, okay? Group number 3, just for the hell of it, was the control group. They've never had experience with a lever, never had experience with a panel. We just stuck them in a room, turned on noise, and all those dogs in group number 3, they eventually went over to the panel and started pushing it and shutting it off. So group 1 and group 3, they really were successful because history is everything and experience is everything. But group 2, not only could they not escape and avoid, but once you put them in the room and you put that square panel in there, they didn't do anything. They just continued to sit there and do nothing. And the only way you could take group 2 to do anything was to take the dog and physically guide their nose to the lever, have them push it to shut off the noise. And they had to do this over and over and over again. So group 2 became helpless. Everybody followed the logic here. Okay. Interesting thing about group 2 with the dogs, that when you put them into a group situation to socialize with other dogs, and again, if you ever had your dog go to doggy daycare You watch your dog on the video cam and they're smelling and sniffing and doing all kinds of stuff, dog stuff, right? These dogs all had reduced aggressive tendencies. They had reduced social dominance. They cowered in group situations. They had reduced food and water intake. They had exaggerated attention to external cues. They were hypersensitive. Anything that happened in the environment, the dog would freak out. They had a reduced preference for sweet tasting foods. I'm not sure why that's the case. I have suspicions I'll talk about in a second. Potentiated fear conditioning, which means is that when you're doing fear conditioning to teach something to be afraid of something, these dogs immediately were freaked out and got afraid. And when the fear stimulus was reduced so that extinction was taking place, these animals were very slow in learning that there's no more connection. There is something that we call neophobia, which is a fear of novel environments and novel stimuli. And finally, they engaged in what looked like anxious kinds of behaviors, and they had a reduction in social exploration. They just cowered in the corner and sat there and did nothing. Okay. All right. Well, what does this mean? Well, back then, and again, this research was done in the 70s, mid-70s. And what Seligman concluded from this is that it's not the aversive event, it's not the noise itself that is the problem. It's the fact that they have learned that the aversive event is uncontrollable. And that causes helplessness. So he basically said, helplessness, this is a cognitive process. That was the conclusion in 1976. But things have changed since 1976. And one of the big changes that happened was that Seligman's collaborator, Steve Mayer, decided he wanted to no longer be an experimental psychologist, and he went back to school to go into neuroscience because he believed that there was something more going on than cognition. So he went to school, completely went 4 or 5 more years after he had had a PhD for a long time, just so that he could learn neuroscience and be a neuroscientist, be able to go in, cut open the head, cut open the brain and the cranium, and start taking a look at what's going on inside of the organism. It takes a lot of training to do that, a lot of guts to do that too. And this is where we are right now. I'll explain the theory to you. Passivity. This is this freezing and crouching and not doing anything, or heightened levels of anxiety are actually what we call default unlearned responses to prolonged bad events. This is our physiology for this. It's the same physiology that happens at the level at which if I come up with a little hammer and tap you on your patellar tendon, you know what's going to happen to your leg? It's going to come up. There's no cognition involved in that. There's no thought involved in that. This is the way we're built. This is the way we do this. It defaults to this system. I'm going to explain exactly where it is, but just as a sneak preview, it's called the dorsal raphe nucleus. What is that exactly? This is a picture of the brain. This is the brainstem. Everybody has one of these things. That's why we're here today, right? This is where the dorsal raphe nuclei reside in the brainstem. And it sends out serotonergic activity and neurotransmitters throughout the brain's selective areas. And what they found out is that when you stimulate the dorsal raphe nucleus, behavior freezes completely. You get frozen, not moving behavior. Okay? That's if you stimulate that. Now the question is, how the hell do you stimulate the dorsal raphe nucleus? Right? I knew you were asking that. Here's how you do it. Stressors. When there is a stressor in your environment, it activates the dorsal raphe nucleus. And the goal of the dorsal raphe nucleus is to get you to freeze in your spot and don't move. Don't do anything. Stay there. Now, what's really cool is that up here is something called control. And what they found out, what Steve Mayer found out and his colleagues, is that If you take these same animals that are under these conditions and you teach them methods to control their environment, to turn off the aversiveness in the environment, it stimulates the prefrontal cortex. And when you stimulate this part of the brain, it shuts off the DRN, just like a light switch. It's all pre-wired, genetic, and this is the way we're built. It's not a psychological thing. This is all physiology. And we know this to be a fact. They've got data on this that's interspecies, including human subjects. And the way they study this is that they'll put them through stressors, similar to what they did with the dogs, but they'll do it with humans with noxious noise. And they'll introduce the stressors, and they find out that the DRN lights up when this happens. And when you look at their behavior, they don't make any escape responding. But if you take the time to show them how things work and how to do things to make their lives better, it's this area lights up. And as soon as this area lights up, this one dims. It's that reaction. Okay. So what does this mean? It means that passivity that we see this freezing up with folks can be overcome by enlisting activity of the frontal cortex. And the way you do that is teach them to control their environment. Now, this has incredible neural, I think, explanations for what I have been doing and what psychologists have been doing in psychology for a really long time. It's called exposure therapy. I don't know if you guys are familiar with this. The idea here is that if you expose a person to an event, an aversive event, it does give rise to physiological activity. But if you keep exposing them to that over and over again, extinction takes place. They stop responding that way if you just keep exposing them to the stimulus over and over again. Turns out that's not a good idea. And here's why. It means that when you sit down with a person and they tell you they've had trauma, sitting down and reviewing the trauma with them to go back to the roots like a psychoanalyst would do is probably the worst thing that you could do. And here's why. All you're doing is you're activating the DRN in sessions. And what you're going to get is either no real reaction, or you're going to get a person who's not going to come to sessions anymore and they drop out of sessions because it's too aversive for them. They can't handle it. Okay. What it means is that if instead you expose them to control first, here's how you can control it. And teach them that first so that they have it in their repertoire to be able to shut it off. Then you work on exposing them to this stimuli. You don't just throw them into a situation and expose them to the aversive stimuli to get it to go down. You need to do preparation work. And the preparation work is basically preparing them for the future. It's what we call future-oriented treatment. Teach them problem-solving skills, crisis response plans, role play and assertiveness training. You can teach them other ways to gain control over their environments, but don't expose them to the stimuli yet. Teach them the skills first. It's sort of the kind of thing where if I wanted to teach you how to drive, I'd probably take you into a classroom and teach you how the car works first, before I stick you behind the car and say, go to it. There's I-25, have fun, right? You got to do first things first. Okay. All right. So what does this mean? They call this the hope circuit. That is, if you teach a person to be able to hope about the future, the circuitry will take care of everything that needs to be done. So you want a response of expecting future bad events will not be permanent. If future events, if they're bad, they're not going to be global. And they will not be uncontrollable. You'll be able to do something in the future. And that's what you're teaching them. The event that you're experiencing right now is temporary. It's local, and you will be able to control it in the future. By the way, the whole idea behind ACT, this is it. This is why it's so darn successful, because this is exactly what they're doing rather than exposure. Exposure therapy versus extinction. I just got done teaching a mental health curriculum to 13 practitioners across the state. And we just went through this, and every one of them use exposure therapy. And they said it's been bugging them for years. Why does it work for some individuals, but not for others? And when they started to see it's not the exposure that does it, it's the teaching that gets them cured, teaching them control. And they've already started looking back at their data on their clients, and they're going, oh my God, this is why my client was not successful. I could not get the teaching involved. They dropped out of therapy before I could teach them how to control it. Okay. So it's teaching control. It's teaching them how to take control of their environment, to stand up and do things for themselves, okay, rather than relying for somebody else to do it. And the errorless exposure therapy is just that, it's errorless. You don't throw them in a room, you systematically introduce them to the problem, a little bit at a time. They try the solution, they're successful, great. Let's step up the exposure and try a little bit something different. Let's try a little bit more aversiveness. Can you still do this skill? And that's the way the exposure therapy should actually work. It's exposure plus teaching, not just exposure. Okay. Any questions? How did I do? 4 minutes. Any questions on this? Now, we do have kids that we have got here who have been exposed to trauma. And we are doing just this. We are establishing rapport with a lot of the kids, but we are giving them choices. I was just in a session with Reed yesterday, and everything we asked this kiddo to do, would you rather do this or would you rather do that? And he will say what he prefers to do, and we honor that immediately. Okay, even if it means, you know, he asks, you want Dr. Kupfer in the room with us while we're working together. And if he says no, or shakes his head no, I'm out of there. I never knew I was that traumatic to a kid. But at the same time, I could come in and I could, you know, a kid would want to work with me, which is kind of nice. But little by little, he slowly, it's just wonderful to watch this kid slowly working with other kids. He was playing ring toss yesterday with Reed. He's smiling. He's actually vocalizing now, which he was not really doing before, but now he's vocalizing. He's telling riddles, jokes. And to me, it made my day completely yesterday. Reed and this kid left the room, the Hope room, and raced down the hallway. And by the way, you're not supposed to run in the hall, but exception to the rule, because when this kid runs, it's not elopement. He's buying in to the enthusiasm. And that to me is treatment results. I could overlook the running because that was great to see. And they ran down the hall and turned left to go into the assessment room, but he kind of hung out in the corner. And as I was walking down the hallway like this to go to turn left, he just leaps out and goes, ah. And it just made my day, because that is a cool reaction for a kid who's gone through this kind of situation. And it's going to be this way with all of our kids. It just takes a little bit of time. But I think part of the thing that we have seen here is that I didn't just rush in and start doing ABA therapy with him. I was very slow and deliberate on how I do this, the same way we do it with, I don't want to use names, but all of our kids were doing the same sort of thing, because we know they've had a rough life. They've had a lot of crap, and so have the families. So when we learn about what the families are going through, a lot of the stuff with the kids starts making sense, and as well as the way the families are interacting with the kids. So any other questions on trauma and trauma informed, most importantly? Yeah, please.
So you talk about trauma and you just talk about like Teaching prior to doing any kind of services. So one of the techniques is that I use when I'm meeting with clients is when first they identify where they are, and two uses the zones of regulation, which is something I've always used. Before you start anything with the kid, see what zone they're in. And then you can gauge what you can do with it. And then if they're like running in the yellow or, towards red or even blue, do an exercise with them like breathing or just grounding themselves. And I think they're going to be more effective with any types of therapies that you want to do with them. Put them in a calm state prior to doing anything with them. Because you're not gonna, as you're not gonna get them to learn anything, if they're coming in already tight. They're gonna stay tight when you're trying to do this therapy. Yes.
Yeah,
A lot of deep breathing, so one of my favorite things about these kids, I have a new chime. So the simple grounding is that you ring the chime and have them stand on one foot as long as the chime is. Because they have to concentrate and keeping their foot up. And they're listening to the bell. So it takes away their thought of any of those things that tighten them before they do. So just simple grounding. And just getting them into where they are at that time. Not what happened before they came in, or what happened, that constantly runs through them. Yeah.
Yeah.
And that's probably the best way to start. Yeah, like a couple of kids that used to come in really like. You might want to do a fun game or maybe a little one a little bit harder, but just possibly do that back and forth. Then you bring them down and out to bring them.
yep. Or getting them to just gain control of doing something that gives them some degree of satisfaction. For example, not necessarily only calming down, but what Reed will do is he'll bring this kid into the hope room saying, what would you rather do, this or that? And part of that is playing soccer in this room. And he gets into it. It's a lot of fun, but it brings him down from where he is coming into this program. As well as the kiddo that you're familiar with, that we're working with. He comes in way ramped up because he's having a terrible time at school. But he's come into our program and he's doing great. I never expected this kid to do this well this quickly. But it's
but he may use manipulation too.
but again,
that's
manipulation.
That's a learned behavior.
And it's control.
Yeah.
He's able to control that way. What we need to do is to say, okay, you've learned to control this way. Let's give you some other options. That if you try this way to control it versus this way, this is what's going to happen. You'll get much more reinforcement out of it. And at that point, it's just teaching and fading a new form of control. Okay.
So if we think about how the brain is reacting, so from anywhere from birth all the way on, where they experience that trauma is where the brain is wired. Every time they have that trauma response, there's the fight response. So kids that have exposure to trauma over and over again, that response is always heightened, and they never come back. Typical kid will get that exposure and then they drop back in. So a kid that is exposed to trauma over and over, they're always in this level. And it's going to take a lot more therapy to bring them down or bring them. So that's a difference between your like one that the instant when they're acute practices and then the one that are exposed to
PTSD for a long time and
Yeah.
it's cyclic over time.
Yeah.
Cool, guys. Thank you all very much. Appreciate it.
Thanks, Jeff.
Yep, you're welcome. Have a good one.
You too. Bye.
Yeah. Yeah.